is. He'll be explaining to us what they've been doing in Germany and what we can learn. If you've worked in the isolation unit or area, you'll understand that using your stethoscope is a challenge. You cannot, not unless you have a stethoscope specifically dedicated for that area, but also sanitizing it and things like those. So we'll be able to learn from Dr. Anguche how best we can use ultrasound if you have the facility, if you can be trained in it. And this will be a very interesting discussion. So I'd like to welcome all of you to this session. Karibuni sana. Dr. Anguche, you can take over.
Yeah, I should just click on begin and it starts, yeah?
Yes.
Can you see my slides? No? Yeah? Yes?
Yes, we can see them. Yes.
Okay.
Yes,
So
yes,
let
we
me
can
see.
see them.
Okay. It's always a pleasure being back home. The nostalgia and seeing familiar faces, hearing familiar sounds. So like I had promised earlier in the year that I would put together a few slides about ultrasonography in COVID-19 patients. And I have titled my talk today, Lung Ultrasound during the COVID-19 pandemic. But I'd like to actually generally talk about ultrasonography in critical care medicine. And I like, at the risk of sounding vain, I always like to introduce myself. Like Dr. Kalondo has graciously introduced me. My name is Anguche Amukupule. I come from Kenya. I trained at, I was born in Nakuru, trained at the University of Nairobi for my undergraduate. And then after undergraduate, went to Moi University Teaching Hospital for my internship, where I did 12 weeks. And because I was so good, I was given 2 weeks in every rotation at the end of it all. So I ended up being the last guy leaving the hospital for internship and got sent to Kapenguria. I did a 6-month stint in Kapenguria, left the government, went to Mombasa, worked for Pandya for 1.5 years, and then left for Germany. In Germany, I trained in internal medicine and pulmonology in North Rhine-Westphalia, did my specialty examination for the 2 specialties and did my European diploma in adult respiratory medicine in Milan. And after that, did allergology, somnology, and critical care medicine. And right now I head the Lostau Lung Clinic, Lostau Pulmonary Critical Care unit in Lostau. So I'll show you what we're talking about. That's the hospital where I work, and the yellow square shows our intensive care unit for which I'm in charge. And this looks very, very bizarre. You see a massive forest surrounding the hospital, and indeed, it is a hospital. And I actually try to go into the hospital through the back and walking through the woods. And this has a historical background. In the days gone by in Germany, lung hospitals, chest units were nothing else but sanatorium for tuberculosis patients. And it was, chest units were consequently built in the suburbs of big cities for 2 reasons. One, because they believed that the air was clean and it would be beneficial for lung patients. And 2, they actually were trying to prevent contagion in the metropolis. So that's why the clinic is actually about 20 kilometers from Magdeburg, which is the state capital of Saxony-Anhalt. So before we all go to sleep, I would like you to take these 6 points with you home and to think about it, ponder over them, And if you have objections, suggestions, criticisms about them, do write me. As we all know, lung ultrasound has been discussed a lot in literature, extensively, in personal opinions, in observational studies. There are very, very few randomized controlled trials that compare different imaging modalities. About 10 years ago, when I started training, when I started my journey to become a pulmonologist and a critical care specialist, you would actually have appeared as a madman if you would have suggested that ultrasonography was a viable imaging modality for the chest. But now, over the years, chest ultrasonography has really established itself. And in relation to the current pandemic that we have right now, the COVID-19 pandemic, it has been now established as, that there are actually relatively uniform changes depending on the stage of the disease in COVID-19 patients. But we have to also appreciate the fact that these changes are the same changes that we actually see in viral pneumonitis. For example, CMV pneumonitis, for example, HSV pneumonitis, and so on. So these changes are not specific to COVID-19. But when you have a positive RT PCR for COVID, or you have suggestive CT imaging, then you can actually, in quotes, say that the ultrasound findings that you find on your COVID-19 patients are specific for this illness. As we know, the chest X-ray is actually a disastrous test for screening for COVID. If you compare this with a CT or compare it with the ultrasound, this is actually the poorest imaging modality. And I would say that relatively, because, for example, in our setting in Kenya, the chest X-ray is only about the imaging modality that is open to us. So when using this modality, you would probably be unless the COVID-19 is very advanced, the very early subtle features are not actually, you cannot see them on a plain chest X-ray. And this has to do with the fact that you have this very small, actually microscopic viral particles which go into the terminal bronchioles and the alveoli, and for some reason they actually prefer the areas, subpleural areas, and this is an area which is actually not very well visualized using a CT, using a chest X-ray. But for other comorbidities or morbidities occurring with COVID-19, for example, pneumothorax, for example, the pleural effusions, which are never major in COVID. They are there, but they are never major. Things like superinfections, bacterial superinfections causing pneumonia, bacterial pneumonias. Then a CT, chest X-ray could actually come in. But you have to really relativize all this, because a chest X-ray is already very limited when a patient is able to actually stand, and if you are able to get a clean AP picture. But when a patient has all these sorts of cables, a patient has tubes, a patient has all this gadgetry, then the quality becomes even limited in terms of what information it can give you. Other things that an ultrasound can be used for during this pandemic, and generally in critical care medicine, and that's what we actually do in our unit, not only for COVID patients, but for everyone. We do cardiac ultrasound, we do abdominal ultrasound, we do vascular ultrasound, lung ultrasound. This allows us to have a holistic approach to our patient, yeah, because at first everyone was fixated on the lung, but with time, as time went by, then everyone started realizing that COVID is a whole body kind of illness. So in short, it's a very, very convenient and a very, very highly useful tool in the context of the COVID pandemic, but also generally as a in the critical care practice. So now we have the take-home message. Now we can all sit back, relax, and go to sleep. Anyway, I'm just kidding. So what are the potential utilities of lung ultrasound in COVID-19 patients? And I would like to say not only COVID patients, because actually every patient, and I have a bias for critical care, but also patients who are on the floors, on the normal floors. Lung ultrasound is a vital part of examination of the patients. This modality of testing or examination is non-invasive. You don't have to expose the patient to deterministic or stochastic difficulties that arise from radiation, ionizing radiation. It is associated with a minimal disruption, logistical disruption. And this is not just a buzzword. Think about it this way. You have a critically ill COVID-19 patient, and we'll localize the example for to COVID-19. And I'm just describing what goes on our unit every single day. So you have this guy. He's on a pneumatic mattress, a pressure mattress to prevent bed sores. He is morbidly obese, like many of our patients are. And he is either orotracheally intubated or he has a tracheotomy. He has ECG cables, he has a nasogastric tube, or he has a percutaneous gastrostomy. So for you to actually get him to be examined, for example, in the CT, in the radiology department, you have to get him from the intensive care unit vent, put him on a transport vent. You have to get all these cables onto their mobile version, and that takes about 30 minutes. And then only then can you transport this patient to the radiology suite. And even then, on top of that, you have a nurse who has to go with the patient, and you have a doctor who has to be there at all time. So if you had this method that you can actually do at the bedside, and it is quick, it is reliable, it is reproducible, it is sensitive, and it is easy to do, then by all means, any reasonable person will prefer it. And on top of that, ultrasonography is actually cheap. Of course, this is also relative. Getting a good ultrasound machine, and there are many, there are stationary ultrasound machines, and you have the mobile ultrasound machines. And nowadays, you only need a probe, and there are programs, mobile phone programs, which actually allow you to image. So there's that whole range. Acquiring them might be a one-off expensive affair. I use a GE, a state-of-the-art GE ultrasound for my COVID patients, and we bought it like 1 year ago, and it cost about $60,000. But after that, all you need is gel. is ultrasound gel. On top of that, once in a while, repair costs. So what's the evidence of lung ultrasonography or ultrasonography at all in critical care medicine? During the Ebola outbreak, first of all, the evidence that is currently available is being extrapolated from other fields, but we have a few decent works from China and from Italy, and a few publications are starting to emerge here in Germany and France and England that actually show that ultrasonography, bedside ultrasonography, helps to actually put it all together, to actually put the clinical puzzle together. So you go into to the patient, you have taken the history, but sometimes in the critical care setting, you actually have no time to, you have no opportunity to do the history. Then you physically examine the patient, but with ultrasound, you can actually get so much information. And Henwood showed that during the Ebola outbreak, where other imaging modalities were not present because of the infectiousness of this illness, ultrasound was able to actually help them in taking care of the pregnant women, pregnant mothers they were taking care of who had Ebola. They were able to actually provide them proper fluid therapy. And the irony of it all, this was studies which were actually carried out in limited resource environments. So these were not like in the West, carried out in the West, so that one could argue, no, those are, we are thinking globally, but we want to act locally. Those are things that don't apply to us. Actually, this would exactly apply to our Kenyan situation. And there's the other thing that with ultrasound is possible, and that once in a while, or not actually once in a while, regularly. Our center is a training center, is a training hospital for the University of Magdeburg. So we usually every 6 months, I have a change of registrars on my intensive care unit. So that means every 6 months, you have like shutter that gets drawn back. So you have the level of skill goes back what ultrasonography is concerned. So the beauty about all this point of care ultrasonography, and especially lung ultrasound, you have your ultrasound machine that is dedicated to the COVID-19 area. It doesn't move from there. And whoever goes in, it could be a nurse, it could be a registrar, it could be me, or it could be my other consultants going in. So what we do, we have a Wi-Fi connection with a monitor somewhere that is not infectious. And you can actually communicate with the person doing the examination, and you can tell them what to do, and you can tell them what is supposed to be seen and so on. And that leads to saving of personal protective equipment. It leads to, it means that many people, you don't have to be, because critically ill patients, and especially COVID-19 patients, anyone who has taken care of them knows that they are very, very, very work intensive. So it means one person relatively inexperienced, relatively, who is relatively new can actually be guided.
Oh, so it's like they're neglected.
Bitte? Pardon? Pardon, Dr. Kalundu? You're trying to say something.
Sorry, let me just mute Dr. Maritim briefly. Sorry about that, Dr. Anguche.
Okay.
But now, from your own sources, even like from your fellowship graduates,
Okay, I had already alluded to what one would consider as an ideal test. It should be quick, reliable, reproducible, and deliverable at the bedside. And this with a high sensitivity and specificity. And I think with the right skill set, or with the right guidance, this could actually be provided by the ultrasound. We had already talked about lung ultrasound in comparison to the chest radiograph, in comparison to the computed tomography, the CT of the chest. But just to be clear about one thing, we know, and there are good studies that have come out of China which show that the CT should actually be the gold standard in the diagnosis of COVID-19 if there is a high index of suspicion. And Peng and colleagues showed this earlier this year. But the truth of the matter is, a CT is actually a finite resource. Even if you're in a good center, a center that primarily doesn't have money problems, you're not the only one, you're not the only department that is actually in need of use of the CT. So sometimes you have to wait, and the logistics, like we had talked about, are very, very difficult. And that's what makes chest sonography very, very attractive. And there was some work that actually showed that when you do a plain chest radiograph, the sensitivity is very, very poor. And you're imagining these are patients who actually can stand up. Imagine a patient who's lying down and has all these cables and is morbidly obese. So I have listed there some of the advantages which we already have already talked about. And because of this this robustness, when the skill is available and when the standards are kept, because of the robustness of point of care lung ultrasound, the Italian emergency physicians, the association, actually suggested in their guidelines that POCLUS should actually be made like the standard for evaluating, monitoring, and following up COVID-19 patients. So, like you must have taken out of my talk as per now, these are broadly the advantages of a point of care ultrasonography in COVID-19 patients, but broadly in critical care medicine, for the initial diagnosis. And we will see a few pictures, Unfortunately, I was not able to actually put together motion pictures because of technical difficulties, but I can actually later on work on an album that we can post on the KNH website so that it acts as a reference. But we are going to see what we'll be looking for when we have these COVID patients. So initial diagnosis, assessment of severity, monitoring, and ongoing management, for example, trying to work out a ventilation strategy, trying to work out a fluid strategy, trying to see whether other things like pulmonary embolisms or other problems have ensued. The ultrasound could actually play a very, very vibrant role. And I had a look at two different sets of work. One from Peng and colleagues in China. They worked exclusively on COVID-19 patients, and they were trying to actually find out what patterns there are sonographically. And there is also a more recent work from Italy by Volpicelli and his colleagues, and it seems very, very uniform, and it seems like it's becoming quite standard. Volpicelli and colleagues tried to differentiate that into intermediate probability of COVID-19 and high probability, the signs. They tried to make the signs, break up the signs a bit, yeah. But while Peng just puts together general signs, but I would want us to look at all these features as a continuum, yeah. Don't think that the signs that will be found in by intermediately severe patients will not be found in severe patients. It's actually a continuum, and you can actually find a mixture of the two. So when what we usually do, we actually use the curvilinear. First of all, whatever gadget you use, you must actually know that gadget. And that's why I actually avoided putting up pictures of any kind of ultrasound machine, because there will be different machines in different units. The most important thing is you have to know your machine. And what we usually use for chest imaging is the curvilinear probe. You can actually use the straight probe. You can actually also use the echo probe. That's no problem. But standard, as the standard, we use the curvilinear probe. And what you want to look for in COVID patients, and I will show you, don't worry so much about what I'm talking about, because right now it might appear like it might just confuse. But I'm going to demonstrate this in images. So what we'll be looking for is thickening of the pleural. Like I said before, the primary pathology, you have the virus, upper airway. When it changes the flow and goes into the lungs, it tends to afflict the alveoli, and especially the alveoli that lie immediately under the pleura. And because of this, it actually leads in many cases to pleuritis. So you will see ultrasonography, you will see thickening of the pleural line. The line will tend to be irregular. And do not forget this. You will see B lines in a variety of patterns, including just a few B lines interspersed with a healthy lung. I'm going to demonstrate all this, so don't worry about it. You can actually be able to demonstrate consolidations. When that gets a bit worse, these consolidations could be focal, or they could actually involve the whole lobe of the lung, or they could actually be translobar and involve both lobes of the lung. And as the patients start recovering, you will start seeing the appearance of A lines. And I'm going to demonstrate all this. And then you have what Volpicelli tried to describe, but that is just splitting of what Peng and colleagues had shown. And now we go to the practical part of it. Also, this is what we try to do. So we have a COVID patient here, and like I described before, he has an orotracheal tube, he has a subclavian line, and he has ECG cables. Yeah. So the chest, this is how we zone the chest. And one thing you shall see, we try to, of course, not for every, but I actually put, I included a pictogram. But when you are doing an ultrasound, you must always have a pictogram there so that you can indicate where your probe, ultrasound probe, was resting on. So we zone the chest, and zone 1 and 2 is the upper part, zone 3 and 4 is the lower part, 6 and 8 is the left lateral part, and 5 and 7 is the right lateral part. And these are the zones where we'll actually be putting our probe. For example, if I'm looking at consolidations or the B lines, or if I'm looking at pneumothorax, or if I'm looking at pleural effusion. And this ensures that you actually don't miss any part. And if the patient is prone, meaning the patient is lying on their tummy, or let's say 35 degrees on their tummy. We just flip this on the back, and we actually do the ultrasound on the back just like that. So I want to present the schematic representation of what I mean by B lines and A lines. So forget the German, I will translate it. So Rippe means rib. So you have a rib, you have an intercostal space, you have a rib, you have an intercostal space, you have a rib. And there you will see the subcutis, you will see the muscle, you will see all that, and it's nicely gray. And if you have a healthy lung below these ribs, then you will have this hyperechoic line which appears white on ultrasound. And if you look properly with the breathing cycles, if the patient is breathing spontaneously or the ventilation cycles, you'll actually see the lung, a nice soft gray sliding. You'll see the line sliding. You can actually, in most cases, you can't tell which part is the parietal pleura or the visceral pleura. And then you have these lines that look like this pleura being repeated, what we call the reverberation echoes. And in between, you have nice gray, which shows healthy lung. Those are A lines, and they are physiologic. That shows the lung is expanded and the lung is normal. So white line, soft gray, nice gray, soft, nice gray, white line, and so on and so on. On the other hand, I've talked about B lines. You have the rib, you have another intercostal space, you have a rib, intercostal space, a rib. Then you will see lines going down. Instead of going across, they are going down, and they will look like light beams. You'll actually see them moving. So you have a B line, you have nice soft gray, healthy lung. B line, nice soft gray, healthy lung, and so on and so on. And B lines have been correlated with the quantity of extracellular lung water. And we'll see practical pictures of this. So we go on, and now in practice, this is how it looks like. So this one is done correctly. You have a pictogram, and the pictogram just shows the anatomic situation of your probe. So the probe is there. So we are using a curvilinear probe. That's the same probe we use for abdominal examination. And then you see the subcutis, you have your muscle, which is very, very thin on the front of the chest. You have your subcutis, and then this shimmering white line is the pleura. And here we can actually make out the parietal pleura and visceral pleura. And then you see these lines, and actually if it was a motion picture, picture in motion, then you would see this line moving right and left, right and left. And these are B lines. When they are this many, they're actually pathological. But 1 or 2 B lines in a field of view is actually normal. So we go on. Now you see, if you look at this, we still are, first of all, here we don't have a pictogram, which means in terms of quality assurance, this is something I would have to talk to my registrar about, because you always have to have a pictogram, because only that way can you compare how your patient is doing. So we don't have a pictogram, which is a bad thing. We have a curvilinear probe, and then we have the subcutis. Then here we have the pleura, and here we see so many lines, and actually there are no intermittent gray areas. Only here we see a gray area. That means we call that interstitial syndrome, and it means that this person is either overloaded with fluid, or they have a massive interstitial process going on, or their alveoli are completely waterlogged. So the other things, okay, what we are seeing here, this is where our probe is. And again, it's curvilinear, and this is the direction of the sound, the ultrasound. So we have pleural effusion, which is hypoechoic. When it's uncomplicated, it's completely black. Then we have, that's the chest wall going there. Then we have the diaphragm from the chest wall going like that. This hypoechoic line is the diaphragm. And below that, you have the liver. And one thing you want to see is the lung usually doesn't look, it doesn't have the ultrasound characteristics of the liver. So when they both appear to be the same, that is what we call hepatization of the lung. And it's actually, this is a patient who had a pneumonia. And if you look further in, this is still the lung, and you see this dots, hypoechoic dots. Those are what you would see as bronchoaerograms on a chest X-ray or a CT. And then what we have here, what I'd like you to appreciate. Now, this is now what heroes are made of. And this is very, very interesting. A normal lung, when you put the curvilinear probe, here again, we don't have a pictogram, which is actually a bad thing. We take the curvilinear probe and we put it on the chest wall. And here you see also the subcutaneous tissue, the muscle, and then you see the rib, and behind the rib, the rib doesn't allow the sound to go through. So you will see black after the rib. And this is another rib. You will see black after the rib. And then this nice gray, this is the pleura, and you can see a repeat of what seems like the pleura. That is what we call, like I mentioned earlier, reverberation artifact. So what is this line? Also, if you are looking at the keyboard of your ultrasound machine, you have a trackball, and on the left, you will see a button written B mode. You click on the B mode, then you go into B mode. Then this line will appear. And then you use the trackball to actually bring the trackball into the intercostal region and through the lung. So what you will see this picture, the upper picture on top of your field of view, and you will see this bottom picture at the bottom part of your field of view. Some imaginative guy called this the normal seashore sign. That means you see this haziness there. That means you have a shore, that's the sand. And here, these lines, these parallel lines, dark, whitish, those are the waves coming to you. If you are resuscitating a patient and you put that, you do that on the chest, and you see this, then you know that they do not have a pneumothorax. And that's exactly the opposite. So you do the same thing. You have a curvilinear probe, you put it on the chest. No, this one was a straight probe. So you put it, what we use for vascular sonography. So you put it on the chest, and after putting on the chest, you can see the rib here and the rib there, blackness after the rib, showing that sound that doesn't go through the rib. Blackness after the rib, sound doesn't go through the rib. This is the subcutaneous tissue. But here you suddenly see something very, very bizarre. You actually don't see in the middle some nice gray. You just see, these hypoechoic lines through and through. And when you look at the keyboard of your ultrasound, the left side next to your tracking ball, then you will see the B mode button. Press on it, and then you get this line, which you will put between the two ribs going through the presumed lung. But what you see, you don't see a seashore sign. You actually see lines throughout, and they look like the barcode you see on your goods at the supermarket when you buy something at the supermarket. And this is a sign of a pneumothorax. When you're resuscitating someone whether they are COVID patients or normal patients. And you see this is a resuscitation. This is a pneumothorax. And we had a very, very interesting case the other day. We had this lady, not a COVID patient, an asthma patient, intractable asthma, tried to treat her conservatively, failed, intubated her, or tracheally intubated her, and then tried to ventilate her, tried to actually break the bronchospasm. She got steroids, she got short-acting muscarinic antagonists, she got long-acting muscarinic antagonists, she got magnesium. We even, gave her sevoflurane. Sevoflurane, that's an anesthetic that is known to actually break bronchospasms, but nothing working. Then what happened? After a few days, one day in the middle of the day, early morning, she actually just crashed. No blood pressure, no heartbeat, and so on. So we started resuscitating her. And one of my registrars, actually we had already, after we started the resuscitation, we actually called the radiology department to actually come with a mobile radiology gadget. But it usually takes about 10 minutes and so on. So one of my registrars held the probe, the straight probe on the lady's chest. And this was the picture we actually got. And what happened after that, we actually, without a chest x-ray, we actually put in a tube, and it was very impressive. And a heartbeat, a blood pressure. So I cannot underestimate the importance, and the robustness of these modalities, imaging modalities. And then here, any of us who have actually held the ultrasound in the hand know what this is. Here again, if I was doing quality assurance, there's no pictogram. That is not right at all. It should not be encouraged. But what you see here, again, the curvilinear probe, you see the subcutaneous tissue, then you see blackness, that is pleural fluid, and it's uncomplicated. Then you see the diaphragm there. It should go to the chest like that, and then immediately under the diaphragm, you have the liver. And this tail-like structure, which is hyperechoic, that is the whatever. That is the atelectatic lung. So these are other examples of pleural ultrasounds. Curvilinear probe, you see pleural effusion. You see pleural effusion, sorry about that, I jumped a slide. And here you can see this hyperechoic strands, and these are fibrin strands. When you see that, then you start thinking that the pleural fluid is actually complicated. Here you actually see a very septated pleural effusion. That's a complicated effusion. And here you can actually see the pleural effusion with an atelectatic lung. And here you have your diaphragm. And then here you still have a curvilinear probe. You have the subcutaneous tissue. And here you can actually see this tail-like structure, which is the lung. And here you actually see total blackness. And when you see this, or dark gray, because this is the blackness, which shows a reactive pleural effusion. You see the diaphragm there. But what you see here is total blackness of the liver. Not of the liver, of the lung, which says that, which means that the nitrogen, which actually acts as a splint for the alveoli, has been driven out, and the oxygen has been absorbed. So the lung fell together, which we call obstruction atelectasis, and that happens a lot when you give your patient a lot of oxygen for a long period of time without giving them enough PEEP. And the other things that an ultrasound can be used for, and this was really interesting. We know that sometimes when you actually get pulmonary embolisms, and we know that with the immobility and the hyperinflammatory status that COVID causes in the body, this is actually a very, very good playing ground for thromboembolic events. And we know that sometimes when you actually suffer pulmonary embolisms, you actually suffer also pulmonary infections. And we know that pulmonary infections are very, very characteristic. You have these areas that are near to the pleura, that are triangular, that you see very, very nicely on the chest X-ray, on the CT, and even in ultrasound. Here you see, this is the subcutis, you see the pleura, and here you can see this triangular gray affair. That's an pulmonary infarction, and this is the normal lung. So this I had already alluded to. Yusuf and DeLuca had already shown that they had actually done a lot of work on viral pneumonitis, the changes of viral pneumonitis, and the people who are now working on COVID actually see a lot of similarities. And we've already talked about the changes. You see B lines interspersed with healthy lung. You see confluent B lines. You see here B lines that are almost confluent, and you have healthy lung there. Here you see a consolidated lung and accompanying pleural effusion. So, but as a caveat emptor, sonography, you have to actually interpret chest sonography in reference to the already pre-existing comorbidities of the patient. For instance, if I have a patient who has something like asbestosis, or he has something like post-tuberculosis syndrome, or he has, let's say, lung pulmonary fibrosis already, and things like that, of course, the imaging will actually not be as straightforward as I've tried to make it seem. In such a case, you would actually have to look to actually do a CT to actually be able to orient yourself properly. And it also, all these changes depend on the status, or on the level, or how developed the disease is, yeah? So I have already alluded to that, the advantages of chest ultrasound. And one thing, I love this Gattinoni concept. I had already talked about it in my last lecture, but I like to actually speak about it again and link it to ultrasonography. Knowing what we already now know from what I have already alluded to, we can now tell that it would be relatively easy using ultrasonography to differentiate the two types of COVID-19 patients. And again, I'd like to point out that these are not two types of patients that differentiate from each other. This is a continuum, so that you have the L type. This is the beginning, towards the beginning of the illness. You have a patient whose lung has low elastance, but for that, he has a very, very good compliance. And he is relatively easier to ventilate. That means you don't need all these high pressures to actually ventilate them. And we actually know that if you use high ventilation pressures, and especially positive end expiratory pressures, then you actually set off a mechanosignaling, and you could actually worsen the patient's prognosis, or you could actually push them to the cytokine storm, and so on and so on. In these patients, the elder patients at the beginning of the disease, these are the patients where early proning might actually work, as opposed to later in the disease when the H-type phenotype has actually come in. When you have a heavy lung, it is water clogged, and the patient is severely and refractorily hypoxemic. Such patients have to be intubated, and they have to, you actually have to use very high PEEP values, and you have to try recruitment maneuvers. We do that, we only do that once in our unit, and if the patient doesn't respond, then we don't do it again, because we know there are studies, recent studies that are showing that very frequent recruitment, and especially in patients who actually don't respond at the first time, is actually detrimental. It causes baro and volu trauma. So we've talked about that recruitability, and there's work by Volpicelli that shows that. Then in general, I will fly past this very, very fast because I see time is starting to evade us. There are elegant studies. Liechtenstein did show, but of course, COVID was not around then. He did show in patients who had ARDS and had a lot of extravascular lung water, comparing PICO, which means also pulse contour cardiac output measurements, and lung ultrasound, orienting yourself with the B lines, correlated actually very, very well. And we know PICO is very, it's invasive. It could lead to infection, bleeding, and you really have to know how to use it to actually get any reasonable values out of it. So as such, especially in a resource poor environment, the ultrasound, and maybe when you combine them with other modalities of checking whether the fluid status is, how the fluid status is, meaning ultrasound of the heart, looking at the strain of the heart chambers and looking at the inferior vena cava, maybe that could actually increase the precision of fluid therapy. But as we all know, that the data about this combination is actually not very, very robust. But it's something we use very, very frequently, actually as a rule on our unit, and we have had actually very, very good results with these methods. COVID-19, we know, affects the heart directly through cardiotoxicity of the virus. We know through when the patient gets intubated, the mechanical effects on the heart due to the mechanical ventilation. You have things like, the interaction, heart-lung interaction, right heart strain, and so on. Using an ultrasound, you can actually be able to monitor these things properly, and actually adjust your treatments accordingly. And there's good work that actually proves this, but this is outside the scope of this lecture. And on top of that, the downstream effects of cardiac dysfunction can actually be assessed and actually treatment tailored accordingly using the ultrasound. If you have congestion of the liver, if you have problems with the gallbladder, you have problems with these systems, you can actually be able to tell these problems early with the ultrasound. As far as the renal dysfunction is concerned, we know the COVID-19 actually does affect kidneys, and about 20% we have series that show up to 20% of patients with COVID suffer from renal dysfunction. But the ultrasound, in this case, we use it to actually rule out obstructive uropathies. And I can tell you a poignant story that actually occurred on our unit the other day. We had this elderly gentleman, 79 years old, COVID positive. He had actually withstood the acute ravages of COVID. We had tracheotomized him, and we were in the process of weaning him from the respirator. Then suddenly, of course, nothing happened suddenly. Over a number of days, his kidney retention parameters started rising exponentially. And in every shift, the nurse was complaining about him passing a little so very, very little urine, and the urine was changed with blood. So we were on the verge of despairing, thinking now this guy suddenly had a bad prognosis. But I made the call and asked my registrar to go back there again and actually show me the kidney ultrasound, show me the blood ultrasound. And voila, there we had our answer. This guy had a hyperplasia of the prostate. The prostate was enlarged. The balloon of the catheter, the transurethral catheter, was in the prostate, and that explained the macrohematuria. And because he was dribbling, once in a while he would actually pass urine, but not enough. But the major finding was in the bladder. The bladder was, he was like a pregnant woman. It was like a gravid uterus. And he had the calyces were completely full. The ureters were also distended. So what we did, we inserted a cystofix. That's an emergency suprapubic catheter, and we relieved that, and we actually watched as his renal function did get better. And the other thing that ultrasound helps, it helps in venous access. Actually, in our part of the world nowadays, it would be considered malpractice if you try to actually gain vascular access without the help of an ultrasound machine. And of course, pulmonary embolism I had talked about. Okay, literature talks about airway securement of airway using the ultrasound. We actually don't do that a lot in our unit. We actually, because we have a video laryngoscope, 2 video laryngoscopes. We have a bronchoscope, several bronchoscopes. So we actually see no need of using ultrasonography for accessing the upper airway. But before every tracheostomy, we usually try to look at the anatomy of the upper airway of the trachea. We want to look at the thyroid anatomy, because once in a while you actually have not very nice surprises and you have bleeding when you're doing the punctional dilatational tracheostomy. So we had already talked about this, so I will jump that. So before I end my talk, I would like to just, point out that we live in a very, very interesting time. We have 2 compelling and sometimes opposing priorities. We have the priorities, we have the duty to our patients to actually treat them and get them well. But at the same time, we actually do not know enough about this scourge to actually necessarily be necessarily able to actually give the best care for this patient. So you have this duty to your patient to actually treat them to the best prevailing scientific knowledge and according to your experience and according to the wishes of your patient. But you also need to keep learning, because there are many, many things that we're actually learning about COVID-19 that are not similar to other pneumonitis and changes that happen in viral lung infections. But I think critical care ultrasonography is a critical skill to learn. I'd be willing to actually run workshops maybe twice or thrice per year at my own cost. Every time I find myself in Kenya, I try to come every 3 times, and we can actually take 3 days and actually do this. And the learning curve is very, very steep, but once you have mastered the technique, then you will be the guy, you'll be the hero, you'll be the guy who saved that person. So of course, there's a camp which says chest sonography is hype, but I would dare say that this is a group that hasn't actually routinely worked with this. Like I always say that even before COVID, that was routine for our unit. We did whole body ultrasonography for every patient who landed in our unit to actually know the current status and to be able to have a reference point when the situation changed. So having this experience, I would only vote for this method that is, in terms of cost and in terms of flexibility, in terms of robustness, according to me, the best option now is. And about decontamination, every unit has its protocols, and I found a social media hashtag or site that shows various ways of disinfecting an ultrasound machine and so on, and various and different machines. And that was the end. If you have any questions, if you have any quick criticisms, if you have any complaints, I will take your questions now.
Thank you, Dr. Nguche, for that educative and informative session on lung ultrasound. We truly learned a lot, most of the things we didn't know about. Before we go to the Q&A, because I'm only seeing one question there, I wanted to ask you, on what day did you start noticing changes, lung changes in the patients who had COVID-19 disease?
Actually, that's the thing. Actually, there has been series of studies. There's a guy, he's called Professor Poschel. He's at the Vienna University. He actually has done a series on positive patients who are symptomatic, both ultrasonography and CT scans. And actually, many people have changes. They already have changes before they actually have symptoms. So every patient we have had on our unit who has come because of COVID-19, acutely or because of complications of COVID-19, you actually see these changes. And they're actually reproducible. And you actually, that's very, very interesting, because as they come in, they have these B lines, and as they get worse, you actually, these B lines become confluent. And as they start to recover, you actually see these B lines actually become rare, they rarefy, and you start seeing a healthy lung. And for other things, you know, pleural effusion. Pleural effusions are COVID-19 patients, according to my experience and from literature, most of them do not have massive effusions, but they do have, you know, slight effusions. And things like superinfections with pneumonic consolidations and complications like pneumothoraces during ventilation. Those are things that through ultrasonography you can actually be able to actually demonstrate.
Okay, thank you for that. How do the radiologists and radiographers out there in Germany view this? Whenever you do, there's a camp that does not, as you said, that does not agree with the point of care ultrasound, especially for lungs. So how have you been able to manage them or convince them? I've seen the technology that you're using Wi-Fi, and there's somebody who goes in using handheld device. But are you asking them to report for you later, or are you just able to continue?
No, you can see them real time. You can actually, because you have a screen in some non-infective area, you can actually see them. And actually that, it sounds very grand, but it is not grand. Actually, about 3 years ago in the site newspaper, I actually read the site, and I have today's Thursday edition. Mm-hmm. If you translate it, it means the time. There was an article about the internet connection in Nairobi being more robust than in Berlin. Mm-hmm. So actually, it should not be a problem. And all modern ultrasound machines, they actually have this capability. And the truth of the matter here in Germany, we actually one of those countries which are using ultrasonography. And the Italians also use ultrasonography liberally. So here, the camp is not very, very strong, the opposing camp, but I would want to imagine in the Anglo-Saxon world that actually the I know the UK is actually coming on board, but I know in America, the camp is actually very, very divided. There are those people who dismiss it outright, and there are those people who actually find it very, very useful. But as the evidence solidifies, I actually think that this is going to gain traction. And I would encourage anyone and everyone, this is not, it seems very, very complicated, but it is not complicated. I'm not the brightest guy there is, yeah? And I actually was able to learn this. So I actually think anyone who wants to do this and dedicates a little time to it will be able to actually learn it very, very fast.
Thank you for that. We have a few trained medical officers and ICU specialists in Kenya who are trained in point of care ultrasound, but as the radiology side is still a bit not so clear on whether those are images that they will take.
Yeah,
so we
my
still,
friend, just 1 second, one second. I have to actually correct this, yeah?
Yes.
My dear friend, Dr. Irene Givinji, a radiologist, no less, writes here, I think you mean M mode for normal tissue sign and barcode sign, not B mode. How could I make such a mistake? Yes, it is M mode. Thank you, Irene. And I hope you're doing well.
Great. That means she was attentive. Thank you, Dr. Irene, for that.
No,
yes.
She's not only attentive, she's actually one of the best radiologists I know.
Awesome.
So she was actually listening for mistakes.
Yes, and Irene, if you're still here, we'd love to hear your views on chest, point of care ultrasound, chest ultrasound. Is it something that we should embrace? Is it something that we're still not clear about? Because we do need a bit of training for the frontline healthcare worker, the medical officers, maybe the clinical officers who are the first line. So before we order a CT scan, before we order a chest X-ray, as we are monitoring the patient, we could be doing something for this patient, as you've showed. There's something that we can continue doing for the patient as we wait for a CT scan to be processed.
Actually, the CT scan is just, for me, it's actually the reference. And I will not repeat a CT scan unless I think the patient actually has like a pulmonary embolism or they have another pathology that has come on top. But if I think I'm just still dealing with the complications of COVID-19, then I will actually use, we actually use ultrasonography on our unit to be able to follow up, to be able to direct management and so on. So it's an invaluable tool. And like I said, if you guys could organize sessions every time I'm in the country, then we could actually do something. We could actually I could do the clinical part, and I'm sure Dr. Givinji Irene Givinji would be willing to actually partner with me to do the really radiological aspects of it. But it's actually a skill that I think every person in critical care medicine should actually learn, and every other person who does chest medicine should actually be able to work with.
Okay. Thank you very much. So there's a question from Dr. Joy, and she's asking, is there a standardized protocol for holistic approach ultrasound that can be rolled out in the intensive care and emergency units?
We actually have, I have developed a standard operating procedure for our unit. We can actually share that so that I can translate it, share with you, but of course that would take time, yeah? Because I have quite a bit on my plate right now, but we can actually translate that and share it out so that the most number of patients can be helped. But there is indeed a standard operating procedure that we usually use.
Okay, thank you for that.
And is that Dr. Christine Joy, the cardiologist? She actually taught me. I'm sure she doesn't remember me, but she taught me. I was one of those lackluster students in her class.
All right, so from Dr. Valentino Lema, Valentino saying, this is very elaborate, it's a comment. This is a very elaborate discussion on ultrasound in COVID. It highlights the fact, as you stated, the learning process in COVID-19. I'm seeing a few questions that are non-ultrasound related, so I hope if you don't mind, I'll ask you.
Ask them.
Yes. So there's somebody who's asking whether, but this is still ultrasound related, can chest ultrasound replace CT scan chests? And
No, that is actually no, that I would say no. Actually, like I pointed out, the CT scan is the gold standard. And we know that actually there are many patients who test negative. And of course, we know why. We have an idea why that happens, because you get the infection, it happens in your upper airways, and as soon as it goes down into your lung, the swabs are likely to test negative. But these patients who actually come with symptoms, they test negative, the upper airway swabs are negative, and in the CT, we're actually able to pick this. And people know, we know, like this series I was talking about, Professor Poschel in Vienna has actually demonstrated even the people who are symptomatic, who actually test positive, when they have CTs done, they actually show lung changes. Mm-hmm. So the CT is the gold standard. But if you don't have a CT, the ultrasound is the next best possible imaging modality. And if you've already obtained a CT, so you have your reference points and you know where you actually geographically can actually place your probe, then it obviates the need to actually do a CT scan again.
That's true. All right, I'm seeing a very interesting comment. Somebody saying, I think in Kenyan schools, we lack this training on chest ultrasound, which if radiographers and radiologists are taught, it would be of much help, especially in county hospitals which lack CT scan. And I think this is true. I would love to hear from a radiologist or a radiographer about your curriculum. And we also seen a danger or a risk of task sharing. Whereby now the emergency physician, critical care physician is actually more specialized in chest ultrasound compared to the sonographers who are actually trained in that particular role. So we would really love to hear what the curriculum is all about. Are you just taught about abdominal pelvic ultrasound and cranial ultrasounds, or what else is being taught in school? That would be a very interesting thing to know.
I think it's very, very important, first of all, by physicians actually mastering ultrasound. And by the way, in Germany, that belongs to the curricula. There are courses that are offered by the professional bodies that you must actually have attended to do your specialty exam. And I think it's never a question of actually stealing this from the radiologists. It has to do, for example, as a chest physician, I interpret my chest radiographs before I actually look at the radiology report. Because I know as a clinician, I actually have a little more information, because the radiologist will actually tell me, give me differentials. They'll give me differentials of what it could be. But I will know what it's likely to be because I have the information from the patient. I have examined the patient. I have most likely talked to the patient. So this is complementing. At the end of it all, if I actually am stuck, then I will call in the radiologist. And we are lucky here in Germany because we actually have this specializations. Like in my unit, I actually have a chest radiologist. So they actually they are experts in chest imaging. So their experience is actually spectacular. So when I get stuck, I call them in.
Okay, thank you for that. I've unmuted a few people who raised their hands. Dr. Jessica Wambani, Hilary Kosgei, Marlene Okoth,
please.
Geoffrey Cheriot. Please feel free to give your input. Dr. Wambani, how are you?
I'm fine, thank you. Thank you for the presentation. It was a bit too theoretical, but still it was.
That's not theoretical. These are things we're actually doing. It's not theoretical. It sounds theoretical. Maybe if you haven't had the experience.
Can I just finish and then you will comment?
Please.
Yeah, because I trained in German, by the way.
And where did you train?
I was in Köln.
Which lung clinic?
Kinderkrankenhaus, Universität Kinderkrankenhaus.
You're a pediatrician. For how long did you train there?
I'm not a pediatrician. I'm a radiologist.
Oh, okay.
And I trained in pediatric radiology. And then I was at Nud and Zud Clinicum in Nuremberg in 2008. So I really know about German. They use a lot of ultrasound, and they use a lot of ultrasound because of radiation safety. That's why they don't do other things. They start with ultrasound, the basic. And by the way, the people who actually do ultrasound, as you say, if you are a chest physician, you must actually rotate 6 months in the radiology unit and master your area using ultrasound. And before you even are taken out as internal medicine postgraduate, you must pass radiology training, and it's an exam you do. It's not like here where you just have to rotate and that's it. There it is an exam. And
exactly, it's quality assurance, yeah.
Yeah, so I think ultrasound has a role, but in our setup, I think we are trying also, because those who are now doing masters, they rotate in radiology, and they get the glimpse of what you are talking about. And as somebody said, the images, they are not like what you'd really, because you should have told us which probes to use. But
I talked about the curvilinear probe. Actually, the major probe we use for the chest for us is the curvilinear probe. But you can actually also use the echo probe.
What frequencies? Which frequencies?
You see, I actually can go into that. But you see, the majority of people who are actually listening to us are actually not radiologists. And if I was to...
No, don't. Medicine is very universal. Please, and don't confuse us. In fact, in Kenya, we have data units. If you come back home and you go around, you'll find we have beta units with very good images. We are not so backwards as you think we are. So I want us to be very,
Dr. Ambani, you're being tangential, and I don't think you're actually being fair, yeah? And I'd like to request you to actually end your question, because I will not be in a position to answer.
Yeah, I'm a radiologist.
Yeah, so please, no, I don't, you're being fair. Yeah, so I'd like to actually decline answering your question.
Sorry about that.
Yeah, I think that's actually a personal kind of thing, and I think I don't think where she's coming from. Why is she now starting to?
Okay.
Anyway, who's the next person?
All right. So there's a question. Let's go back to Dr. Raj's question, and he was asking about use of steroids.
Yeah.
Yeah, so he's asking what's your opinion with regards to the use of steroids for nebulization in COVID-19 patients. Some claim it's life-saving and prevents death. So is that what you're using? Are you still advocating for it? Last time you're very categorical, we should not use.
Yeah, but evidence has since come up. There's this study that was carried out in Oxford, about 2,000 patients and so on, and they were giving dexamethasone. They compared patients who received dexamethasone and those who didn't receive dexamethasone, and it actually showed that the outcomes seemed to actually be better to favor the patients who are getting dexamethasone. So I think it's actually, but that was intravenously. About nebulized dexamethasone, I can't really, I'm not alive to any literature that points to any specific direction about this.
Okay.
Yeah.
All right. Then there's a comment from Dr. Frederick Mugo Nganga.
Yeah.
And he's saying, congratulations, Dr. for the beautiful presentation on lung ultrasound. I have thought and read on lung ultrasound, particularly on normal routine pediatric respiratory exam, particularly in this COVID era of social distancing. The stethoscopic findings appear inferior in comparison to the lung ultrasound. What is your take on this area? And still in the same breath, somebody's asking, Dr. Ogaro from Eldoret is asking, how sensitive is chest ultrasound versus chest x-ray in pneumonia? in children?
Also Dr. Ogaro, I remember him from my stint in Moi. Yeah, about children, I actually do not have data about this. Yeah, so I will pass on that. I'm not alive to, actually that's not my province, so I actually can't talk much about that. And the colleague who asked about stethoscope, or just, was that, or what did he ask? Stethoscope versus ultrasound?
Yes.
Yeah, remember the stethoscope, actually the depth of what we auscultate is not more than even 3 centimeters in the depth. I think actually if I had a choice, I would choose the chest ultrasound. But of course, like we all say, we all know, the expertise must be there. Yeah, so one has to be relatively well trained in it for one to be able to actually reap these benefits of chest ultrasonography.
All right.
Yeah.
Dr. Titus is asking about ultrasound findings in paranasal sinus in COVID-19 patients. Have you been lucky enough to do any of them in your patients in your unit?
No,
All
actually, we don't do paranasal sinus ultrasound. That's the province of the ear, nose, and ENTs. We actually don't, that's not our province, so we don't deal with that. If we have a problem there, we actually call in an ENT.
Okay.
Yeah.
And then the final question, which is non-ultrasound related, Willie Socheng is asking, when do you make the decision to intubate a patient? I know you're very not keen or very eager to intubate. So he's asking, when do you make the decision to intubate, and what's your experience compared to the Italian experience? And
I actually think, I still insist on this.
Yes.
Actually, you have a patient, you know, whom, let's say this, peripheral saturations which are catastrophically low should not be the only decision that leads you to actually intubate a patient. You should look at how much work the patient is doing, work of breathing. If, for example, they are flaring their nose and you can actually see the muscles or the extra muscles of breathing actually being put into action, then you can actually tell that there'll be impending failure of the respiratory pump. And you can actually try to do non-invasive ventilation, but this will only help if this modality takes away the work of breathing of the patient. You see, but if the synchrony between the patient and the machine is not there, then that will increase the work of breathing. And if that doesn't work, that is the time when I say, no, we have to intubate the patient. The most important reason to actually unload him as far as the work of breathing is concerned, and try to better the oxygenation. But just a saturation that is low, and I always repeat this, there's this picture, poignant picture of a lady lying on her tummy, going through her Facebook while her saturation is 54%. But when you're going through your Facebook, then it means your neurological status is actually very, very good. Because oxygen is just not, taking up of the oxygen. It also means how is your HP, the transporter of your oxygen. It also means how is that oxygen being given up in the periphery to the cells. It also means that how is this oxygen being used in the mitochondria. And all these factors have to be taken into consideration. And the body is very, very intelligent. If you're taking into very little oxygen, then it will increase the heart rate so that the same red blood cells they pass through the lungs very, very often and take up a lot of oxygen. The process of giving up the oxygen in the periphery will be more efficient. The process of using the oxygen in the cell will actually be more efficient. So just a saturation is actually not enough to intubate a patient. That's my philosophy, and that most likely is going to be my philosophy for a long, long time. not just for COVID patients.
All right. Thank you so much, Dr. Anguche, for finding time. We truly apologize for that small incident that has just happened. We apologize profusely. These are usually learning sessions, and I hope we all learn something from it. Every time you attend this session, I hope you go home with something. You pick something from it, because that is the intention for this forum. Our intention is to educate and share knowledge.
Dr. Wambani should actually, excuse me, she should actually get in touch with me personally, then we can actually talk about these nitty-gritties, technical nitty-gritties, yeah? But I actually found it inappropriate for her to expect me to actually put in, you know, the finesse of ultrasonography when...
Doctor, I do apologize. And don't dwell on it. I do apologize to you if you are offended.
What we do, we can actually privately have a talk about this. Then we can actually talk about the private things about the fine things about chest ultrasonography. Okay, that's my offer.
All right, thank you so much, Dr. Anguche, for that. And we really hope whenever you come back home, you'll be able to take us through some more ultrasound training.
Yeah.
And we'll see whether we can be able to organize at least a session next time you come back.
Yeah, I think.
Yes.
Yeah, thank you very much for the opportunity. I thank everyone who actually made time to attend the session. I enjoyed the session, and I hope I have inspired you to actually get to use the ultrasounds that were donated in that public partnership, the GE contract.
The MES contract.
Exactly. They don't gather dust that more people use them. Yeah. They are not just left in the hands of radiologists. I hope that I have been able to achieve that tonight.
Yes, you have. I can see a comment from one of the attendees, and he's saying this is quite advanced learning. Probably we've been underrating the usefulness of ultrasound. This for me is eye-opening. Appreciations for the presentation and participation. So yes, I believe we've picked something. We just need to practice the skill. The more we practice, the more we see, or the more we know what to look out for.
Yeah.
Yes, so thank you so much for that. And to the participants who attended tonight's session, we truly appreciate your presence. We hope you've picked something from this, and we'd like to wish you a good night. Tomorrow we have 2 sessions, the experience sharing session in the morning at 10 a.m. And we also have an afternoon session on setting up ICU facility in COVID-19 disease. So that's a very good one to pick up. What do you need to set up your ICU? As you buy your ventilator, what is the bare minimum that you should have? So please log in for tomorrow's session to learn something about that. Thank you so much, Dr. Anguche.
Dr. Kalondo, have a good evening, and thanks for everyone for attending the webinar.
All right, you have a good day too.
Yeah, bye.
Bye.